It should be about to go live. And it's slightly delayed. We will start. Good evening. My name is Onika Williams, and I am chair of the National Bar Association Young Lawyers Division. Welcome to our NBA Black Lives Matter Black Lives Learning Series. Before we begin, we would like to take a moment of silence for the lives lost in Georgia on March 16th. Thank you. NBA YLD stands with our fellow Asian American communities in grief and solidarity against systematic racism and gender-based violence in all forms. We kicked off this series, an NBA Black Lives Learning Series, last month with Black Lives plus Racial Equity Part 1, and it was led by Temi Bennett, our NBA YLD Social Justice Co-Chair. Tonight, we have part 2 of our series, Black Lives, COVID-19, with Dr. Michael Knight. A little bit about the National Bar Association. The NBA was founded in 1925 and is the nation's oldest and largest national network of predominantly African-American attorneys and judges. The YLD is the home of the young lawyer within the NBA and represents the interests of young Black attorneys under the age of 40 years old or originally admitted to practice within the past 10 years, whichever is more inclusive. This year's NBA YLD theme, 2020 and Beyond, recognizing the importance of the young lawyer, has been seen throughout 7 programmatic areas. 1, election protection, voter registration and education. 2, COVID-19 recovery efforts. 3, efforts to eliminate police brutality. 4, 2020 census efforts and 2020 redistricting efforts. 5, professional and skills development. 6, mental health and wellness. And 7, pipeline programs and mentorship opportunities. And now to tonight's moderator, Temi Bennett. Temi?
Thank you, Madam President. Good evening, everybody, and thank you, Dr. Knight, for being with us today. I want to read Dr. Knight's bio so you know that you're dealing with a subject matter expert right now. Tonight, you are blessed to have him share his time and knowledge with us. Dr. Michael G. Knight is a physician and the patient safety officer at the George Washington University Medical Faculty Associates and assistant professor of medicine at the George Washington University School of Medicine and Health Sciences. Dr. Knight is board certified in internal medicine and obesity medicine and practices clinically in the GW General Internal Medicine Practice and Weight Management Clinic in Washington, D.C., where he works with a multidisciplinary team to provide primary care and medical weight management. He completed undergrad studies at Oakwood University and attended the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. He completed residency at New York Presbyterian Weill Cornell Medical Center and was a Robert Wood Johnson Foundation Clinical Scholar at the University of Pennsylvania, where he completed a master's in health policy research. Throughout his career, Dr. Knight has been a champion for health equity and is the founder and president of the Renewing Health Foundation, a nonprofit organization working to empower urban minority communities through health education. He also serves in leadership roles in organizations such as the National Medical Association and the American Medical Association. He has been a featured medical expert on radio, television, and in print news media, and routinely speaks at events internationally and throughout the United States. Dr. Knight has received numerous awards, including the American Medical Association Foundation Leadership Award, Washingtonians Magazine's Top Doctors Award, and the Top 40 Under 40 Leaders in Health Award by the National Minority Equality Forum. As I said, he is very accomplished, and we are so thankful for you, Dr. Knight, to share your knowledge and time with us tonight. And without further ado, I'm going to pass it over to you.
Thank you, Temi. Thank you. Onika, for the invitation to be here on tonight or this evening, particularly because the National Bar Association has a very historic relationship with the National Medical Association, of which I serve on the national board. So we are always love to interface with our sister organization on this very, very important topic. I'm going to go ahead and share my slides so we can go ahead and jump into this very timely topic. And of course, I'm coming to this topic from a position of a healthcare professional. And when we talk about health equity, we know that a large portion of that responsibility does fall on the health professional workforce to ensure equity for our patients. And so if you hear me talking, I'm also including myself in the maybe the problem and definitely in the solution to what we can do to have equity for our patients. And we're going to use COVID-19 as an example of what needs to be done to ensure equity in health. And so the title of the presentation, The Long Road to Health Equity, COVID-19 and the African American Community. So tonight we're going to describe the impact of COVID-19 on the health of the African American community. We're going to identify the root causes of the disproportionate impact. And we're going to also identify the contributors to lagging COVID-19 vaccination rates in the African American community. And finally, we're going to describe the persistent barriers to achieving health equity. So let's jump back 1 year ago to the date, March 18th of 2020. And what was the headline? So this was a headline in CNN. All 50 states had just had confirmed cases of COVID-19. The European Union had closed its borders for 30 days. Millions around the world had been put under lockdown, and government was pumping huge sums of stimulus funds into their economy. We also know at that time that 8,525 coronavirus cases had been identified in the United States, and 145 people died. And I'll tell you, when I was creating this slide and looking back at the time when I went on CNN, what started playing was an interview with Sanjay Gupta, who I'm sure we've all seen, talking about the COVID-19 pandemic and telling people who had risk factors they needed to stay home. And it almost felt like I was going in the twilight zone, because what was known was where we are, what has happened over the last 12 months, we could never have imagined a year ago when this began. So let's fast forward to March 18, 2021. Today, where are we with the COVID-19 pandemic? We have 121 million cases. 121 million cases around the world, with 2.68 million deaths in the last 12 months. In the United States alone, we have seen 2.7 million cases and over 500,000 people have died. And I think sometimes when the number gets so high, we no longer are able to enumerate it. We're no longer able to visualize what 500,000 people looks like or feels like. That is multiple towns, communities that could have just been wiped out to come up to this number. So many people have lost loved ones. And so I want us to definitely remember those as we talk about this topic. So in March 2020, this is something that came out. It said the novel coronavirus has upended life as many Americans know it, spreading across the country like wildfire. It has affected nearly every state and territory, leading some to call the virus the Great Equalizer. The Great Equalizer, and this was in March 2020. So was COVID-19 the Great Equalizer? Absolutely not. And we know that it wasn't the Great Equalizer because we see the disproportionate impact that COVID-19 has had on communities of color, particularly the African American community. And again, I'm going to be focusing on the African American community tonight. Yes, there are a lot of challenges in many different communities, but I think it's important for us to be able to identify what is happening, particularly in the African American community. What we know based on most recent data out of the CDC is that African Americans are 1.1 times more likely to be infected by COVID-19, are 2.9 times, almost 3 times more likely to be hospitalized, and almost 2 times as likely to die from COVID-19 as individuals in the white or majority populations in the United States. African Americans has experienced 15% of all deaths, even though we make up about 12% of the population. And in 33 states and in DC, more than 1 in 1,000 African Americans have died from COVID-19. 1 in 1,000. 1 in 1,000, I think, is so important. So when we think about you going into a stadium, you going into a mega church, you going into any facility that has a large number, imagine 1 in 1,000 people have passed away in our community in so many locations across the country. In addition, the African American life expectancy in the United States has fallen by almost 3 years. And remembering that African Americans already had low life expectancy compared to the majority population, and we have lost 3 years in the past 12 months. Let's jump back and try to unpack how exactly we came to this point. In February 2020, as many of you all may remember, at that time, the coronavirus, COVID-19, was really present in Asia. It had started to go into Europe. It had just started coming into the United States. And we really hadn't heard about people of African descent being affected by COVID-19. It also led to almost the understanding, people thought, well, maybe people of African descent are actually immune to it. The first person of African descent that came out in the news with a COVID-19 infection was a Cameroonian student who was studying in China at the time. Contracted COVID-19, received treatment and recovered in a few weeks. And a headline coming out of China at that time, as China's doctors confirmed, an African blood genetic composition resists coronavirus after student cured. So various unsubstantiated reports spread online that genetically people of African descent were immune to COVID-19. And at the time, we didn't know any differently. You know, obviously, as a healthcare professional, I was quite skeptical of those kind of reports, because as we've seen with diabetes, with high blood pressure, with HIV, with prostate cancer, with breast cancer, you go down the list, African Americans have a disproportionate impact. And so maybe it was wishful thinking that we thought that people of African descent had some innate immunity against COVID-19. And the states and counties were not giving us race data. We didn't know who was being infected by race. We didn't know who was dying by race. But unfortunately, in April 2020 is when the shoe dropped, when we can go back to remembering those COVID town halls and discussions that were happening out of the White House at that time. Dr. Fauci came out and said, you know, health disparities have always existed for the African American community. And this crisis is shining a bright light on how unacceptable that is. What did we see in April 2020? The data started hitting the headlines. And I remember this very clearly because this is the time that we started going on the news programs, started getting calls and said, you know, Dr. Knight, we need you to come on and talk about African Americans and COVID-19. Now, mind you, just a month ago, we were believing that maybe African Americans were immune. And now the narrative has completely changed to, in South Carolina, 51% of the deaths happening in the African American community, though they only make 30% of the population there. Chicago, 70%, Louisiana, 70%, Michigan, 40%, Washington, D.C., where I live and am in practice, 80% of the deaths from COVID-19 at that time in April 2020 were in the African American community, even though we made up just less than half of the population in Washington, D.C. So why was that? And why is it that we continue to see disproportionate impact of health issues on the African American community? One thing that I know we have heard is if America has a cold, the African American community has pneumonia. And I will move that even further to say, you know, as what we saw with COVID-19, if America has a cold, the African American community is on life support. And it's not because of anything innate. It's not because of any genetic issue. And we're going to unpack the real reasons behind these inequities that are still present today. Knowing that many African Americans suffer from higher rates of chronic disease, coupled with disadvantaged socioeconomic circumstances, we could have, and I will include here, we should have anticipated that COVID-19 would hit low-income African American communities harder than others. So let's jump to the determinants of health. We often talk about social determinants of health. What does that mean? We know that counties with the highest portions of African Americans had more crowded living conditions, lower social distancing scores, higher unemployment, lower rates of health insurance, and higher burdens of chronic disease. Again, not because of a genetic reason, not because the community had decided that they want to live in crowded conditions, but unfortunately because of historic marginalization that we are all aware of that has affected the African American community. So we know that in American epidemics, and this is something that really stood out to me, is that race, unfortunately, is a pre-existing condition. And we also know that race is a social construct. Of course, there is no gene that gives me full lips, curly hair, and diabetes, hypertension, and COVID-19. There, unfortunately, is a social construct that places me in a box and has my lived experience following a certain path. So we know the disproportionate impact with many African Americans being socially prone to COVID exposure. There was a higher incidence of comorbidities that were fueling complications. And we also know that those comorbidities made the infections extremely more deadly. And that is linked to segregation, concentrated poverty that still impacts communities today. So let's start with prevention. Okay, so we're gonna unpack why we saw this disparity, why are we having challenges. We have to start from the beginning. So COVID-19 prevention, stay home, save lives. We saw this everywhere. We still see it now. When everyone said, to save ourselves from COVID-19, just stay home. Wash your hands, cough into your arm, dispose of tissues. Here, avoid all non-essential travel, right? Call ahead before going to the clinic or hospital. Work from home. Isolate yourself at home. Avoid touching your face, avoid crowds, and avoid contact with others. And the reality is that being able to maintain social distancing while working from home, accepting a furlough from work without compromising our personal finances, indulging in a plethora of virtual events. You don't have to worry about feeling socially isolated because we can have our Zoom happy hour, staying home with children who are now in virtual school, or quarantining in a separate living space than family members when there was a potential infection. These are privileges, and they're not accessible to everyone. Now, of course, many in the African American community, does not just because you're an African American community, does not mean that you are financially challenged. Doesn't mean that you don't have the ability to do these things. But the reality is, for a large portion of our community, these are privileges. Because of many of the living conditions, because of frontline jobs. Let's talk about frontline jobs. For example, in New York City, where I'm originally from, about 30% of essential workers were African American. We know many of these jobs are jobs that historically have been a part of our community because the benefits, because of the job security. Be thinking about the Postal Service. We're thinking about a variety of city and civic industries where we have been able to find employment. And for individuals who didn't have an opportunity for graduate medical or graduate education for a variety of reasons, and have allowed us to begin to try to build wealth in our communities. But unfortunately, those same jobs turned out to be increased exposure during this pandemic. Though they are often essential for the functioning of society, we know that many pay near minimum wage and provide little or no sick leave, and don't compensate workers for the risk that they incur from those kind of exposures. So when we think about the misleading, confusing, contradictory statements that were coming out of the prior administration, the shifting guidelines, we were at risk, we were impacted. So if you're an essential worker and you walk out the house today to work and they said, oh, you don't have to wear a mask unless you have symptoms. Who do you think had to bear the brunt of that information? That was not the best advice at that time. Now, of course, we didn't know everything we know now about COVID-19, but those decisions impacted the community. So what do we start doing? So this is immediately after the information came out about the effect in the African American community. There was a numerous social media posts that were going around about how to prevent COVID-19. You will remember the lemon water, standing out in the sun, gargling, okay, all of these variety of things, taking, overdosing ourselves on vitamin C and a variety of things. And we said, we have to get to this. And so the National Medical Association, we worked together, we started to do Facebook Lives, we started talking about how can we address the questions that the African-American community has about COVID-19. So let's talk about now, right, we already discussed prevention, but once infected, the death rates began to soar in our community. When compared to whites, African-American adults are 60% more likely to be diagnosed with diabetes, 40% more likely to have high blood pressure. Women are 20% more likely to have asthma, 50% to be more likely to be obese, and less likely to have well-controlled chronic medical conditions, in addition to be more likely to have the conditions in the first place. Now, sometimes we hear these rates so frequently that we actually become numb to it. And it's almost like there's an expectation that if you're part of the African-American community, then you're going to have poor health and there's just nothing you can do about it. But again, I'm going to come back to this. There's no genetic factor that makes us phenotypically African-American, and also gives us all of these risk factors for almost every chronic condition available. So when we have a conversation as why the African-American community is disproportionately impacted, we cannot stop at, oh, that's because African-Americans have more diabetes. That's because they have more high blood pressure. No, we need to push past that and say, well, why do they have higher levels of diabetes? Why do they have higher levels of high blood pressure? It's only then that we'll start addressing health equity, and we'll come back to that. So poor cardiometabolic health was one of the most intense and most important major risk factors of increasing COVID-19 severity. So almost 1 million US hospitalizations, 63% were attributable to these issues. The number one, obesity. Over 30% of individuals who were hospitalized for COVID-19, it was as a result of excess weight. To the point where if you really break it down, a 35-year-old, for example, a 35-year-old with diabetes, high blood pressure, and cardiovascular disease or obesity had a similar risk of COVID-19 related hospitalization as a 75-year-old person with none of those conditions, or the same rate of death as a 65-year-old with none of those conditions. And at any age, if you are African American, your risk for a negative outcome was much more or much increased when compared to the white adults. And so that means if you have African American with diabetes and high blood pressure, and someone from the white community with a high degree of high blood pressure and diabetes, the risk still wasn't equal. The risk still wasn't equal. The risk still was higher for the African American patient. And so again, it's not just the comorbidities that we're dealing with. We knew that these comorbid conditions were going to lead to negative health outcomes in the community. But that did not widely inform what we were doing around prevention and testing. Think back, how could you get a COVID-19 test when this pandemic first started? At the first, you had to go to the health department. You couldn't even get tested for COVID-19. And then they said, oh, well, if you have symptoms, if you have, everything that are very mild, just stay home. Don't get tested, just quarantine. And obviously, if you're living with other individuals, it's almost impossible to do that. And there was a lot of spread going on through the community because we did not have access to testing. Knowing that the African-American community had the highest rates of the comorbid conditions, we could have put much more resources into the community than ever before to prevent the outcome that we have seen. Years of research that have illuminated social and structural differences in our communities and make it easier for some to stay healthy and harder for others. We ignored that. Our public health system ignored that. And unfortunately, we saw the results of that. And when I say ignored, of course, yes, we took some things into account, but there were missed opportunities for us as a healthcare organization, as a healthcare community, as a public health community to address it. Like I said, most places that African Americans went for their health, federally qualified health centers, did not have access to testing. much more likely to receive health in a healthcare desert, somewhere where they had to go far to get healthcare. Even thinking about in the Washington, D.C. area, where we have our hospital systems, that's not equitable throughout the district. And so, yes, there was problems with equity in access to testing. So let's go past testing. Let's talk about treatment. Were there disparities in the way that African Americans were treated with COVID-19? What we know is that in many cases, priority scores were used. So when I say priority scores, a patient comes in, if you have 10 patients with COVID, you have 2 ventilators. Who's going to get the ventilator? You have to be able to say, well, who is this ventilator going to help the most? Who is likely to benefit the most from this limited resource? And one of the ways that you can do that is by using priority scores, where you see what's the person's risk of dying, what's the risk, what's the likelihood that this person will overcome this condition. And so priority scores that use chronic diseases as a part of their calculation resulted in disproportionate assignment of lower scores to African Americans. And so these unadjusted scores inaccurately predicted mortality risk and may have impacted some treatment decisions. We know that there are many institutions that did away with these scores or worked to normalize them or use other factors in making these kind of treatment decisions. But the fact is that if we're not intentional about it, then there's a possibility that treatment also was impacted. So at this moment, I'm going to jump back. I want to take you back to talking about the influenza pandemic of 1918. This is not the first pandemic that we've gone through of a respiratory illness. Oftentimes, it seems like we have amnesia when these pandemics come around. And in this case, there's a lot we can learn. 1918, the influenza pandemic killed about 50 to 100 million people worldwide. And in the United States, over 675,000 people died from the pandemic in 1918. Case fatality rate, meaning the rate of individuals that died was 2.5%. African Americans at that time were reported to have lower influenza incidence, meaning they had lower likelihood of being infected. But once they were infected, they were more likely to die. Now, we know that at that time, segregation may have functioned as an unintentional quarantine. So the way that individuals were forced to live, meaning if the respiratory virus is quickly spreading, it's going to spread to people you're in contact with. And so segregation at that time separated many African Americans from white Americans, and that could possibly have been protective. But once it took root in the African American community, we saw it run ravaged because of malnutrition, poor housing conditions, social and economic disparities, as well as inadequate access to care. We know that African Americans in 1918 received substandard care in segregated hospitals, oftentimes would be treated in the basement or other places that were not designed to accept patients, or they would have to find the Black-only hospitals that would give them care. One thing that stood out to me when I was doing my research on this topic was what actually happened in many of the states. When we think back and just see how deeply rooted this inequity, this issue, discrimination was the fact that in Baltimore, when the Black cemetery was full during the 1918 pandemic, they asked the sanitation workers to dig graves for the fallen Black flu victims. And the white sanitation workers declined, said they will not dig the graves, to the point that the mayor of the city of Baltimore had to contact the War Department, today's Defense Department, and ask for Black soldiers to come and bury the dead. So the inequity that we saw at that time was to the point where you couldn't even get a grave dug for the people who had succumbed to the influenza virus. So we know at that time they were dealing with significant inequities. But then where are we today? We're still seeing that the impact disproportionate in our community. 100 years later, we're in another pandemic, and who is at the bottom? Who is impacted, and why is that? And so oftentimes when we see these numbers, we just think, is this just another healthcare disparity? We know that the disparity is a difference between the health of one population and another. We're not talking about why. We're not saying that it's unfair. The disparity just means I see it differently. So for example, if I say that women are more likely to get breast cancer, right? Men can have breast cancer too, but it's very, very uncommon. That could be a disparity by sex. That could be a disparity based on anatomy. And that doesn't mean that something's wrong with that, but it is a difference. Now, when we move over and say, our health disparity is just an inalienable truth in the status quo in America, that's the question we have to ask ourselves. Because when previously I went through all of the conditions that have a higher percentage of impact in the African American community, at what point do we say that this is not right? At what point do we say this doesn't have to be that way? Or are we accepting this as a status quo? So this came out in one of the journals when we were talking about COVID-19 in the African American community. And the author said, do we chronicle these poor outcomes due to COVID-19 complications with the higher burden of cardiovascular disease, poor breast cancer outcomes, higher amputation rates, lower kidney transplant rates, worse rates for maternal mortality, and file it away under health disparities and go back to normal? Or do we really look at these issues and say, are we really dealing with health inequity? The differences in health status or in the distribution of health determinants between different populations, and these differences are systematic, they're avoidable, they're unfair and unjust, and they're rooted in racial, social, and economic injustice, and are attributable to social, economic, and environmental conditions in which people live, work, and play. That's the language we need to be using. We're not just talking about differences that are because of genetics, or because of how somebody looks. We have to acknowledge that the differences in health status, including in the outcomes of COVID-19, are systematic, are avoidable, are unfair, and they're unjust. Now, many of you have seen these photos, and I have take issue with them. I'm going to jump into that real quick, but before I do that, I want you to see this. So of course, we've all seen these photos. Equality versus equity, right? And so equality, we give everybody the same thing. And in this photo, we see the young gentleman here with the purple shirt on. He can't see over the fence because he's gotten what everyone else has gotten. And then in equity, we're giving everybody what they need, right? And so this little gentleman, the shorter stature than the other folks, we've had to give him 2 boxes, and now he's able to see over the fence. One of the things that makes people uncomfortable, they may not realize it, is that someone had to lose a box in this photo. Someone had to lose a box in this photo. And that's the uncomfortable part, because individuals who are used to privilege, individuals who are used to standing on a box when they could look over the fence just standing on the ground more than anyone else, may not necessarily be comfortable giving that up. Now let's talk about health equity. An opportunity for everyone to gain or attain his or her full health potential, where no one is disadvantaged from achieving this potential because of their social position or socially assigned circumstance. And again, looking at this photo, problem. What's the problem with the photo? What's the problem with that photo? The problem with that photo is that in this photo, I'm going to go back so you can see it. The 3 individuals are different heights. So there's an inherent difference between those 3 people who are trying to look over the fence. Maybe the little guy had a genetic factor that made him shorter. Maybe he's just younger than the others. There is something inherently wrong with the little guy that makes him not be able to see over the fence. And so now we have to overcompensate and provide him with another box. And unfortunately, that's how a lot of people think about health equity. No, there's not any communities in the United States that are inherently less likely to have better health, so that we have to go and go the extra mile for them. The reality is that we have 3 individuals who are of same height. That's all a part of the human race. They're all genetically predispositioned to good health, but the realities are different. We can see here the fence upsloping, the ground downsloping, to the point where the individual who's in the yellow, though she has the same height as the others, she can't see over the fence because her reality, her lived experience is completely different and because of factors outside of her control. And so when we talk about equity, yes, we're providing her with additional boxes to overcome a barrier that is specific to her lived experience and that she didn't place. What placed for her is what she got into. And so we have to think about that when we talk about equity. We'll never get to equity believing that people inherently have a problem. We know that equity is affected by social determinants of health, housing, neighborhood conditions, stable income, job security. All of these things are linked to poor health outcomes. And as a healthcare community, as a larger community, in the legal community, what are we doing together to address those social determinants? But also understanding that social determinants is only the beginning of the story, right? Because above that is power and wealth imbalance, labor markets, housing policy, globalization, and deregulation. Those are things that impact social determinants. And above that, institutional racism, class oppression, gender discrimination, and exploitation. We will never address equity in health. We will never achieve equity in health unless we talk about the underlying root causes. And it doesn't stop with affordable housing. It doesn't stop with living wage. It goes to the underlying issues that unfortunately we have not addressed. And that is why 100 years after the 1918 flu pandemic, the African American community continues to bear the burden of disease in this country. So let's quickly jump into the COVID vaccine concern. So September 2020, the survey goes out. We don't have a vaccine at this point. We're just talking about, what's coming, what could be here. 49% of African American surveys said that they would either probably not or definitely not take a COVID vaccine. And of those 49%, folks said they were concerned about safety or lack of trust or have doubts about the government or the healthcare system in general. 61% of African Americans at that time said they had little confidence that the vaccine would be properly tested for safety and effectiveness. That's compared to 40%. We know that this Operation Warp Speed in some communities may have been accepted as a medical miracle. But unfortunately, in many communities who have been exploited in the past, saw that as a possibility for another unfortunate effect on their health. So confidence in vaccine information, we know that only 40% of African Americans that were polled at that time, and this is December, said that they felt confident they had enough information about the vaccine. And overall, 60% of the US population felt. So there was definitely an information issue in getting down to the community. And so we start seeing all of these headlines, oh, Black people don't want the vaccine, and there's vaccine hesitancy, and we don't know why. So I want to talk about why. One of the core fundamental issues is trust. And trust is a fundamental aspect of the physician-patient relationship and the relationship of patients with the healthcare industry. We patients have to rely on their physician to provide them with appropriate information and to act in their best interest. And when we don't have that trust, that's where a lot of the concerns, I like to call it vaccine concerns, come into play. When there's a lack of trust in healthcare, we know that studies have shown African Americans are much more likely than white Americans to say they do not trust their healthcare provider. That distrust is rooted in a history of medical exploitation and contemporary experiences. I'm going to talk about that because a lot of times we like to go back to what happened in the past. I'm talking about what in the past, and I'm talking about to what's happening right now. And this decreased trust allows people to be less likely to seek treatment, but also less likely to accept new therapies. This Reed Tuckson said this, the seeds of distrust in Americans' fundamental societal infrastructures have been deeply planted since our arrival in this nation. And unfortunately, they have been watered daily in our interactions with political, police, and criminal justice, finance, and health systems, among others. So trustworthiness before trust. To ask the African American community to be more trusting, providers, pharmaceutical companies, healthcare systems have to provide convincing and understandable evidence that it is strong enough to overcome the extensive historical evidence that they're not trustworthy. And this is hits home for me as a healthcare professional, because none of us want to believe that we are not trustworthy, that we have done, that we have to prove ourselves. But unfortunately, our community has been exploited for decades, for centuries. We all hear about what we have on the line. And this is what Congresswoman Ayanna Pressley said, history has shown us that we do not have to ask questions. If we don't ask questions, the consequences are grave and in fact, life and death. So we all heard about Tuskegee, right? And this is one thing that a lot of people like to point to when they want to explain vaccine hesitancy. And so I will address it very quickly. And I don't even like to call it the Tuskegee study, because it makes it seem like we're talking about the city of Tuskegee, which is actually very historic in African-American community. It's not Tuskegee University, right? One of our historically Black colleges and universities, but it's actually the US Public Health Service syphilis study at Tuskegee, because for 40 years, the US Public Health Service allowed syphilis to go untreated in 623 African-American men in order to chronicle the progression of the disease. In fact, it wasn't until the 70s, and let's, people like to talk about the 40s and the 30s. No, let's talk about the 70s, when many people were alive that are alive today, where there was a leak to the press that this study was still going on, and that is why it was stopped. So it wasn't stopped because someone woke up and said, we need to do better for the African-American community, or we need to tell these men that they have syphilis and get them the treatment that they deserve. No, it was a leak to the press that led to the end of that study, that unfortunately also led to the deaths of 128 participants. But that's just one example. The medical establishment has a long legacy of discriminating and exploiting African Americans. And these actions are deeply rooted in the collective consciousness of our community. The way that the healthcare system in the past has used Black bodies without consent for its own advancement. We know about what was happening with the medical exploitation of enslaved people, from the periods where African Americans were forced to participate in dissections, medical examinations. There was grave robbing, where Black bodies were taken from their graves to be a source of surgical and anatomical experimentation. We also know about the surgical procedures that were perfected using enslaved women, and that did not consent to that experimentation, and were not even given the dignity of having anesthesia. And so they had to undergo these procedures in incredible pain, because we were being exploited, and there were thoughts that maybe African Americans didn't feel pain as much as others. And so again, centuries of inhumanity are not easily forgotten. And we have to, as a community, and in the healthcare community, I'm speaking to myself here, we have to make sure that we show how we are overcoming those issues. Too often we hear the words health literacy, adherence, hesitancy, and it's a hint of blame, and not really understanding that there's a reason for people to be concerned about vaccines or any new medical procedure. This is something that came out of the American Medical Association and said, as we grapple with the American Medical Association's 174-year history, we must acknowledge that decisions by AMA leaders contributed to a healthcare system plagued with inequities and injustices that harmed patients and systematically excluded many from our physician ranks. So again, the medical establishment has had a history of this. And in 2020, let's talk about today, not talking about the 70s, let's talk about 2020. Kaiser Family Foundation did a study showing that they sampled about 777 African Americans in a very random sampling design that was pretty representative. And 70% of African Americans who were polled believe that the healthcare system treats people unfairly based on race very often or somewhat often. Percent of people who said that in the last 12 months they were treated unfairly while getting healthcare because of their race or ethnic background. 20% of African Americans said yes, they did feel that they were treated unfairly. And 37% of African American mothers said that they felt that in their care or their child's care, they felt discriminated against. And when we ask the community, do we think that doctors providing different levels of care are a part of some of the health challenges we see? They agreed. 54% saying that was a major reason. So we know that in the poll, African Americans are much more likely to report higher rates of being disbelieved, being denied tests, treatments, or pain medications that they thought they needed. And we know that no healthcare provider or health institution wants to believe that they're treating people differently. But the truth is they are. And the truth is it does happen. When we think about the implicit association test as the way to identify implicit bias, we know that in the general population in the United States, most Americans have an implicit pro-white, anti-Black bias. But when we looked into healthcare students, trainees, and physicians, of course, we would expect something different. Individuals who have gone into healthcare, who have committed their life to improving the health of the community. And unfortunately, most healthcare providers also have a pro-white, anti-Black, implicit racial bias, similar to the general population, the same people. And again, not necessarily because they know that it is not walking into a patient's room with a bias, but we have to acknowledge the society in which we are raised. The problem comes, I can't blame you for having implicit bias. The problem comes when you don't do anything to change it, because the fact is it does impact care. Physicians with higher levels of implicit bias often spend less time with African American patients during an office visit. They are much more likely to have their patients reporting a harder time remembering what was said, or less likely to recommend medical treatment that's indicated for African American patients. Implicit bias is a habit of the mind. It can be changed. It can be changed when someone is aware, concerned, and there are interventions employed to change that. We know that contemporary inequities in health include African Americans being more likely to receive lower ER triage scores. So when you go to the emergency room and they determine who's going to be seen first, African Americans are more likely to be put in that lower category, more likely to have longer wait times for interventions, their perception of honesty, as well as the amount of time that they're able to spend with their physicians. We also know there's something called cumulative deprioritization. What is that? What does that mean? In medicine, I don't want you to think about how we as physicians operate. We have to constantly triage and prioritize patients, constantly. When there are 3 critically ill patients in the emergency department, we have 1 ICU bed. We have to make a decision on who's going to get that. We have to think about, we have to clear out the hospital. We need to send patients home. There are 3 patients that are almost ready to go. Who's going to go out the door first? Who's going to get assigned the most experienced nurses? Who's going to get that extra 15 minutes in clinic and your visit? And whose visit is going to be cut short? Implicit bias is a deep subconscious belief about who matters and who is more valuable, that those things begin to creep into practice. And it's over many small decisions. It's not common that your physician's going to walk in and say, you know what, this Black patient, I'm not going to help them. I'm not going to do what needs to be done. But it's those little decisions that is where we see the impact on health. And so we know that inequities in health are ingrained in the US healthcare system. And so inequities are not a sign of a broken system, but instead it's in fact, the system operating just as it was built to operate. So how can the healthcare profession build trust in the African American community? And I know we'll have time for some questions to answer, and I hope we can have some dialogue around this. Some of the work being done, the Black Coalition Against COVID-19 has been doing a number of town halls. We've seen outreach efforts here at GW, at the Rodham Institute, as well as in the Kaiser Family Foundation has been doing work, really putting African American physicians on the front line to answer their questions. And the National Medical Association, of which I'm a part, we formed our own in-house FDA, if you will, to vet the data on COVID-19 treatment efficacy and vaccine candidates. We hosted town halls with churches and universities, having conversations with the Black community. Even myself personally went on YouTube, went on Facebook, Instagram, and started talking about my own experience getting the vaccine and talking about how my patients, what should they look for? What side effects should they expect? And it was picked up on the news, and I can't tell you the number of patients that came to me and said, Dr. Knight, I didn't know about this vaccine. I wasn't trying to do it, but when I saw that you did it, when I was able to talk to you and you addressed my concerns, I felt so much more acceptable. And what we know is that rates of vaccine intent are rising. Now, a majority of African Americans as of February 2021 say they plan to get the COVID-19 vaccine. Vaccine intent is 75% higher among those who have a high trust in research and development. But only 24% of African Americans say they have a great deal of confidence in the development process. So we still have work to do. But we know that individuals that are still disinclined, have concern about side effects, sense that they were developed too quickly, and want to know more about how they work. And these are all valid concerns. And so when I have conversations with patients, I'm never saying you have to get this vaccine right now. No, let's talk about it. What are your concerns? What are your questions that we can answer? I want you to be comfortable and ready. And that's how we have to address it in the community. It's not that the African American community is not concerned about COVID-19. 78% of us know someone personally who has been hospitalized or who has died from COVID-19. I have known multiple people outside of my clinical practice, in my family, in my community, that have been hospitalized and have died from COVID-19. And I'm sure many of you all can say the same. We have been following the news closer than anyone else, and we're more likely to say we're very concerned about passing COVID to someone else. And so when we think about the issues, the access is a larger problem than we like to see or that we're seeing in the news. Hearing about the vaccine hesitancy, the Black people don't want the vaccine, but the fact is a lot of Black people who want the vaccine can't get the vaccine because there's a greater vulnerability. There should have been a larger resource available to our community for vaccination. Disproportionately fewer people of color have been vaccinated across the country. At the beginning of March, only 5.7% of African Americans had received a dose of the COVID vaccine. And we know nationally that was about 20% of individuals had been vaccinated. Now, knowing that 61% of African Americans say that they want the vaccine, why have only 5% been able to get it? We're going to use DC as an example, where vaccinations lagged in communities of color. You can see here the share of the residents that were Black, the areas of people who are familiar with DC, you know where the folks live, and that's not where people were getting the vaccine. Now, they may have physically been going to those areas to get the vaccine, but the vaccine was not making it into the arms of residents in the majority African American spaces in Washington, DC. And when we talk about access, we're talking about where are the vaccination sites located? Are they in my community, or do I have to go across town to get it? How can I sign up? Is it only online? Is there a way for me to call? Can I go to get the vaccine when I'm not working? Have vaccines been explained? Have you addressed my concerns? Knowing the history and how it's impacted the African American community, we have to be intentional about this. So how do we achieve health equity? And I put everyone, how do we achieve it as a global community, not just on the healthcare system? We have to eliminate systemic racism and implicit bias in medicine. We have to establish and adhere to standardized evidence-based practice guidelines. That means if you come in with a heart attack, it doesn't matter what you look like. There has to be a standard of what is provided to you, how we treat you, how we triage you. We have to match the investment of clinical resources to the level of need. This brings us back to the photo that we talked about with equity. We can't give everybody the same thing and expect to have a different outcome when individuals are at a different starting point. The playing field is different. So if you say, I'm going to give everybody, I'm going to put one vaccine clinic in every neighborhood, is that going to solve the issue? Maybe some neighborhood needs 3, 4, or 5 of the centers. And then what do the folks in the other neighborhoods say? Well, that's not fair. Why is that community getting it? We have to get to a point where we understand that everyone's need is not the same, and we have to match investment of clinical resources and resources across the board to level of need. We need to optimize the doctor-patient relationship, which we'll talk about, building trustworthiness and increasing diversity. So that doctor-patient relationship, that trust that you have with your primary care provider, the greater the trust, the better the outcomes, the better the communication. And the better when we talk about health inequities, we need to have that relationship to address it. We know that increasing diversity in the health workforce can lead to improved satisfaction for minority patients, as well as knowing that they are more likely to report receiving a higher level of quality care. We also need to build trustworthiness through partnerships. So building collaborative and participatory programs with the communities that we serve. We want to get away from the hospital, the neighborhood medical center only wants to come to our neighborhood when they have a grant, when they have something they want to do, and when it's done, they're gone. We have to really develop these long-term relationships. As a collective, we have an opportunity. When the dust settles in the wake of COVID-19, let us not allow ourselves to fall into a great amnesia, another forgotten pandemic. Let us remember who this disproportionately affected and why. Let us take this as an impetus for mobilization. Let us begin to rewrite the story of health disparities in America. And in this new chapter, we will be better prepared to offer all citizens a fair and just opportunity to attain their highest level of health. And so with that, we go back to these photos and know that equality and equity are fine, but what we need is justice. And the only way we'll have justice is when that fence can be torn down, when we can level the playing field, when we don't see barriers to equity, when we don't see barriers to social determinants of health as something that just have to be there. Let's not just try to put a Band-Aid. Yes, we need to invest resources, but we ultimately need to address why it is that there is still inequity when it comes to these social issues, and how can we bring justice to communities in need. So with that, I want to thank you again for having me and having this very important discussion with your team. And I hope that you pick something up from this talk tonight, and I look forward to having a discussion.
Thank you so much, Dr. Knight. And I really appreciate you grounding your work in history and walking us through that historical narrative, because that work is really important. And I think that that's a way for people to really get an idea of how pervasive the history is and how it leads to the outcomes we see today. And so with that being said, there was a time, I can't remember, maybe it was around April, May of last year, around the time when Black folks, when we did begin to see the disparity, that a lot of commentators started trying to shift blame to individual behavior, right? And it was like, oh, well, you Black people have to do better, right? Like you are fat, you have diabetes, you have all of these comorbidities, as you pointed out. And so it is your fault, not like, how do you respond to that when people want to shift the focus and the blame to individual culture or behavior?
Yeah, I think people will shift blame because they know it's not right. Okay, so when you see these numbers, when we saw the numbers and said, 80% of people who are dying in DC were in the African-American community, the reflex for many individuals will say, oh, well, it's because Black people aren't wearing masks. That's what Black people just want to hang out. Black people have higher diabetes. They don't want to give up their soul food and these other things. And they don't want to address the much higher level issues, which involve them having to take accountability and having to have an action plan on how they're going to address it. And so I think it's expected, unfortunately, for many of our leaders to quickly go to blaming individuals. Oh, Black people don't want to exercise. Black people don't want to get their weight under control, and not addressing why it is that most African Americans still live to this day in certain communities, why African Americans are not many times able to get out of those places to access healthcare at the same level, and why should it matter as how much money is in my pocket to whether or not I will survive a global pandemic. And those are the answers, those are the questions that have to be addressed, and they're not comfortable questions. And we have to continue to push back on that. And when I see these presentations, I'm pushing back. I said, okay, so you told me that African Americans more likely to have diabetes, that's why they have COVID-19. Well, why do they have diabetes? Let's go there. And then say, well, why are they eating foods that are higher in sugar? And how did the higher sugar foods get into their communities? And why is it much more affordable for me to purchase such an item than to have a nutritious quality food that is inaccessible and that's unaffordable? And I think at that point, we start having a real conversation.
Thank you. And if there are questions from participants that are watching, just go ahead and put them in the chat. So you talked about how at one point, when you started to see the disparities, there was a point where the medical field could have done just more intentional intervention like more widely adopted, but you said that it wasn't done. I'm so excited to have like a doctor here to tell us like what were the conversations in the medical field happening that didn't happen. Why didn't, when we saw race being a predictor, why was there not this intentional shift to intervene leading with race? What were some of those conversations?
Yeah, I think a lot of it has to do with people don't even realize that they're not going to achieve equity with a equality approach. And that's exactly what happened. It was an equality approach. Oh, we're going to make sure that every doctor's office has the testing for COVID. We're going to make sure that every hospital has extra ventilators. We're going to make sure that we get masks in every community. We're going to send the same amount of masks to every community. That's never going to address the issue because every community has a different risk for COVID-19 infection, and every community has different needs. And so the conversation oftentimes in the medical spaces where we're going to go out and get testing wherever. We're going to open up a drive-through testing in the middle of DC. We're going to open up testing everywhere, and everyone pat this up on the back and say, look, anybody can get here. You can get on the metro. You can get here. We're open from 8 to 3 o'clock. So you open from 8 to 3 o'clock. So if I'm working a full-time job, I got kids at home, I can't get tested, right? And so you have to say, well, maybe we need to extend the hours. Maybe we need to have 10 testing centers in this community, and maybe we only need 2 over here. And then you get well, I don't know how fair that is. Well, equity is not fair. Equity is providing people with what they need to address the issues that they have currently. And those are the conversations that we have. And I would say that those conversations were positive in many places. I don't want to paint the field as if this was not addressed. I would say that across the board, the majority of areas were not having an approach that was going to reduce the risk in the African-American community. We see certain places where things were done. There were some physicians who took it into their own hands. For example, in Philadelphia, a Black doctors group went together and was going out and testing in the community, drive up at churches, at different areas where testing was not occurring. They went out into the community. And so that's what I saw. So it was being addressed, but unfortunately not across the board.
So for you, we talked about disinformation and misinformation around vaccines. What was it for you when you said, like, this is important and I myself am going to take this vaccine?
Yeah,
when we know the history. Mm-hmm. When we know the history and like in how Black folks have been exploited by the medical field, like what made you say I am gonna take the vaccine?
Yeah, that's such a great important point, Tammy. And one of the things is that, when I take my white coat off, I'm a Black man in America. So yes, I'm a healthcare professional, but I also know what has been done to the Black community. And so even I had my questions and skepticism. Another part of the challenges with the vaccine is that it had become so politicized. It had become so linked to a specific political party, a specific administration that, we can just be real about it. I did not have high trust with my community, with the African-American community. And so when we say, okay, this is what they're rushing through and this is what they're providing to us, and I don't even trust you, but I'm going to trust what you're giving me, absolutely not. So I had to look at the data for myself. And obviously the benefit is that as a physician scientist, I was able to go through the data, look at the numbers, look at what the studies were showing, and then I felt comfortable with the effectiveness and the safety that I saw. Unfortunately, most people are not able to do that. And so they have to trust and rely on health professionals to do it for them or with them. And so for me, I had to see the data for myself. And so then since then, I have worked to help my patients and those in my community through social media, through one-on-one interaction, to break down that information in an understandable and comfortable place for them so that they can make the right decision for themselves with regard to the vaccine.
And so if you're talking to somebody like a lay person doesn't have, the knowledge that you have, the specialized knowledge that you have to look at and analyze data, is there a trusted resource where they could go online? Like, who would you say, or who could you, if they're not getting their medical facts from a CNN commentator or their news reporter, where would you say folks can go and trust the information?
That has been a real challenge because I tell you, before 2020, we would go to the CDC website, right? You go to the CDC website to get information. And unfortunately, because of the politicization, the CDC website took a real hit in credibility. But one of the positive things that I will say is that has turned around. We saw a report just today that over 3 or 4 multiple pages from the CDC website have been removed. Anything that has not been rooted in science and fact has been removed from the CDC website. And so now I actually go to the CDC website with my patients, because it has now gotten to the point where we're putting science first and we're taking the politics out of it. Politics should never have been involved in the way that we look at health information. And so, for example, some of the new data that came out, recommendations on what people who've been vaccinated can do, saying that if you've been vaccinated and I've been vaccinated, we can be around each other without a mask. That's something that I trust, and looking at the data coming out of the CDC today. So I would say the CDC is a great place. National Medical Association, the Black Coalition Against COVID-19 has a great website with resources. The Kaiser Family Foundation has a Greater Than COVID campaign that has a lot of very good information with resources and references. Again, just because you see it doesn't mean you have to believe it. I'm looking for the footnotes. For those of you academics, you're looking for the footnotes. Tell me where you got that information. Let me check your sources. And so the same way we do that in our everyday life, let's focus on that. So when you go to these websites, look at the resources, look at the references at the end, and do your research. But those are some great places to start.
And shifting back to implicit bias, you talked about the history of it, how it shows up, and how it even, is pervasive still. And we even know, like, not even, before COVID, like, we're thinking on Serena Williams, right? And the bias that she faced when she went through her pregnancy, and doctors just not believing her, right? Like they don't believe, like, this person is a superior athlete who knows her body in and out. She knew something was wrong, and they still didn't believe her, and it almost cost her life. How or what can folks do to advocate individually, right? Like self-advocate, because you can't, like, I can't change my race, and I would never want to, but if I'm in this doctor's office, if I think that he is not treating me as I should be treated, what are some things that I can do to try to let him know that I don't think this is right, and I can, like, self-advocate? What would you say? What would your advice be to individuals, or who are maybe accompanying elders, right? Or like maybe I'm there with my mother or something like that, if I'm able to be there. Granted, COVID, you can't really accompany folks anymore, but if I was able to be there with an elder person, how would I self-advocate for them?
Yeah, that's an important point, Timmy. One of the things that we have to understand is there has to be a trust relationship. It's one thing if you're going into the emergency room. You go into the emergency room, you kind of get who you get, right? You don't know what doctor is working that day, who's there. But I go back to your primary care physician. And everybody should have a primary care physician, because your primary care physician needs to be your advocate, the quarterback for the health that you're dealing with. And it should be someone that you feel comfortable with. I know that it may depend on your insurance, who you can access, but oftentimes there are options available. And so I have patients, for example, who will wait months to see me, and I'm like, why are you waiting months to see a primary care physician? There's so many other, and they're like, Dr. Knight, I needed to see you because I felt like you could understand my situation. We have a similar background, and the trust is built. And then when they go into, or I refer them to a specialist, I send them somewhere else. If they're hearing something that just doesn't sound right, they're like, no, let me just call my doctor. And we work through that, whether I'm speaking with a specialist or whether I'm empowering them to do so. So that's one thing, having the right team. So your primary care physician, having a specialist or other individuals involved in your care that you trust and that you can relate to. It would be great, if they're African-American, wonderful. It doesn't have to be African-American physician, but we know that with African-American physicians, oftentimes it's easier to build that connection. In addition to that, it's being educated about it. So knowing about your health process. So yes, you have diabetes. What does that mean? Do you understand what makes diabetes real in your life? Do you understand the things that affect that? Do you understand why you're taking the medications that you're taking? So it's a lot easier to advocate for yourself when you are an educated consumer, if you will. And I'm not saying that it's someone's responsibility to know medicine, right? You didn't go to medical school, but there are ways to be engaged. And if you're in a physician situation or a healthcare situation and you feel like the care that you're receiving is inappropriate, then you go on up the line. I want to speak to the physician in charge. I want to speak to the head nurse. What does Serena Williams do? She said, look, I need this CAT scan and I need to speak to somebody. Of course, Serena Williams is in a different position, right, than many of us, but we also have to advocate for ourselves and get folks involved. You start picking up the phone, you start calling the patient advocate, people start speaking to you differently. And so if something doesn't sound right, if something is not sitting well, then use that opportunity to advocate for yourself, to bring the people in your corner with you, and also to use the resources available to you to get the care that you need.
And you talked about the lack of Black doctors and how when you do have Black doctors, we have better outcomes. Can you talk about some of the barriers that African Americans face if trying to become a doctor in this country?
Yeah, that's a great point. You know, one of the things that we know is that African Americans really make up less than 5% of physicians in this country, though we make up 12 to 13% of the population. And African American men, it's less than 2% of physicians. We know that for a number of reasons. Again, I'm not saying that you can't get competent and effective healthcare from people of other ethnic or racial backgrounds. You can. You can. We don't have enough Black physicians for every Black person to have a Black doctor. But the facts are that the data has shown that, for example, African American men often have better outcomes when they have a physician of African American descent. The reasons behind that, like I said, is that core trust. So if I can relate to you, if I feel like you listen to me, if I trust you, then I'm much more likely to follow your plan of care. And that's what we see in those situations. When we think about barriers to increasing diversity in medicine, it's the same barriers that you guys see in the legal profession, right? We can't have Black doctors if we don't have Black people passing their MCAT. We don't have Black people who are graduating from college. We don't have Black people who are being recruited from college. We don't have Black people who are getting out of high school, who are being educated and who are being equipped for the process. Unfortunately, we don't have educational equity in this country. And as a result of that, too many of our youth from our community are growing up, going through school, and have not been prepared to pursue the medical profession. And we all need to do much, much more. And it starts at the elementary school level in preparing our youth for careers in health sciences.
And now, if folks wanted to mobilize and get involved, because obviously this is an injustice, that our healthcare system is an injustice. If folks wanted to get activated and get mobilized, like what are some things that they could do to advocate for their community, for African American communities in the healthcare space?
Yeah, so many. So number one, starting locally. What hospitals in your neighborhood, what community health centers in your neighborhood. Often with a community health center, the requirement is that over 51% of the people on the board are patients of that community health center, right? So people can have a direct impact on the care that's been provided. Are you speaking to your local elected officials? What money has been set aside for health development, health promotion in our communities? And again, we don't want an equal piece of the pie. Much more needs to be invested in our communities for us to achieve equity. So I said local healthcare organization, local elected officials, healthcare advocacy organization, nonprofits, the National Medical Association, the Renewing Health Foundation, of which I'm a part of and founder of, doing health education work. Look and see who is doing the work. So yes, when it's diabetes month and we see the American Diabetes Association, you donate there, right? But then also think about donating to the community kitchen on your block that's actually giving low carbohydrate meals to patients with diabetes in your neighborhood. Those are where we need to be putting our dollars, and that's where we can really make an impact. So not only should we be advocating at the legislative level, but we need to be advocating with our dollars.
Can you talk a little bit more about the Renewed Health Foundation and the health education work you do through that organization?
Yeah, so Renewing Health Foundation, you can find us renewinghealth.org. It's a nonprofit organization that's worked to empower communities, urban communities, to really take control of their health through health education. So we've been doing work around breast cancer education, for example. We know that African American women are 40 times more likely to have a poor outcome with a breast cancer diagnosis. We've been working to educate in the community, raising funds for education, providing care packages for women, and now doing more education on social media around COVID-19, around bringing fact-based information to communities who are looking for it, to have a conversation, not just me showing up and saying, this is what you need to know and you need to listen to me. No, I'm coming in and I'm saying, well, what is it that you would like to know? What do you need? What tools do you need to take control of your health, and how can I help get those to you? And that's what's most important.
Thank you. And where can we find the work again?
Renewinghealth.org, or you can find us on social media at Renewing Health.
Thank you. So I'm going to pass it back to you for any final thoughts, and then give it back to Onika so she could close us out.
Thank you, Tammy.
Thank you for sharing your time and knowledge with us tonight.
Thank you for having me. And again, I just want to close and say it's all of our responsibility. You know, as a healthcare professional, this talk is a talk that I've given to my colleagues, and it made us really think about what we are doing, and to either advance health equity or to stand in the way of health equity. And as a community, we have to advocate for ourselves, whether or not you're in healthcare. You know, we need to hold people accountable, hold our local elected officials accountable, and know that we will never have equity with an equality approach. And we will never have justice unless we address the underlying issues that continue to plague our community, and understand that our community has a lot of strength. We have a lot of resilience, and we can use that to achieve equity in health.
Thank you, Temi. Thank you, Dr. Knight. I just want to say that was a masterclass in COVID, in Black lives and COVID-19. For me, I especially picked up on the fact that both of our professions are based on trust, yet both of our systems, medical and legal, have a history of unfair treatment, discrimination, suffer from implicit bias, especially against Black people. So as young Black lawyers and physicians, we live at that intersection. So I just want to personally thank you for all of your work in this space, especially your social media outreach. I can tell you it personally was effective for me. And so I just want to thank you and the National Medical Association. As you mentioned, our Big Bar and the National Medical Association have a long-standing relationship, especially during this time, as COVID-19 has especially affected our communities. So special thanks for everyone that came out tonight. We are also streaming live on Facebook. Thank you to past chair Nick Austin is here with us, and we just have an announcement. Next week, Tuesday at 6 p.m., join us. NBA YLD is kicking off our redistricting project. It's called the People's Map. You do not want to miss it. It's Redistricting 101. Very important, a continuation of what we have done for 2020 census and all of the work we have done around voting. So thank you so much for coming out tonight. We truly appreciate it. And I hope you stay safe and have a good night. Thank you.
Thank you. Have a good night.
Good night.